Hi, everyone. Good afternoon. Welcome to the June 26th session of the Virtual Learning Collaborative, conducting expanded perinatal HIV surveillance through the SETNet program, made possible in partnership with the CDC Division of Viral Hepatitis. So hi, my name is Zakia Grubbs, and I'm a manager here on the hepatitis team at NASDAQ. Joining us today are our presenters, April Rideout and Arlis Jenkins from the Arizona Department of Health Services, and Rachel Biltz from the Allegheny County Health Department, and our moderator, Heather Wingate with the Tennessee Department of Health and HepTAC consultant. The format for today's session is as follows. We will begin with a brief overview by Heather, followed by presentations by April, Arlis, and Rachel, and then we'll have a moderated discussion with Heather. So you all feel free to use the chat to introduce yourselves and your jurisdictions, and if you all have any questions during the session. So I will now turn it over to Heather to get us started.
Great, thanks, Zakia. Let me just share my screen. All right, can you see my screen okay? All right, perfect. So I'm going to be kind of just giving a brief overview of SETNet. Again, I am Heather, so I work for the Tennessee Department of Health as an epidemiologist, and I have been involved in SETNet with the TN team for about 5 years now, but today I'm going to be presenting on behalf as a HepTAC consultant. All right, so first we're just going to discuss what SETNet is. So SETNet stands for the Surveillance for Emerging Threats to Mothers and Babies Networks. It detects the effects of emerging and re-emerging health threats on pregnant people and their babies. We collect data from pregnancy through childhood and use this for actionable items to improve the lives of mothers and babies. And SETNet was originally started during the Zika virus outbreak in 2015. So SETNet aims to determine how health threats affect pregnant people and their infants. It also tracks birth defects, developmental delays, and other complications as these children age for up to 3 years. And the CDC, as well as health departments, use this data for the 4 main goals. And so for 1, monitor and improve the health of pregnant people and infants. 2, link families to medical and social services to get the recommended care. 3, to strengthen laboratory and clinical testing and find emerging health threats quickly. And lastly, ensure public health is ready and prepared to meet the needs of pregnant people and infants during emergencies. So the exposures of interest are as follows. We have current as well as historical. So currently, SETNet is involved with the surveillance on hepatitis C, syphilis, and CMV. Historically, we have focused on COVID-19, Zika, and Mpox. And so for the Tennessee team, we have focused on 3 conditions so far, which were hepatitis C, COVID-19, and Mpox. So here's a list of funded jurisdictions as of September of 2023. So in the dark blue are the funded state and territories, and then the lighter blue are funded cities and counties. A new NOFO went out last spring, and so currently everyone is waiting to hear who will be supported for the future of SETNet, which will begin this year. So how it works. So essentially the health department identifies a pregnant person or newborn who tests positive, either via a healthcare provider, a laboratory, or linking to another data set. The health department then collects more information on the pregnant person, like data positive tests, as well as their infant, like was the infant born prematurely. The health department securely sends the information to CDC's SETNet team. And we continue to collect baby's medical information and lab test results from birth to pediatric visits and continue to send these to the CDC. So health departments and CDC analyze this information, and we utilize these to develop reports on pregnant people and babies affected by these emerging threats. We answer these key questions. So what are the impacts of pregnant people? What are the short-term and long-term outcomes for the baby? And then how can the infection be prevented? Insights from these analyses are used to update guidance for policymakers, the public, and healthcare providers that care for these families, target outreach or resources where they're needed most, and to better prepare for the next threat to pregnant people and their babies. So in addition to conducting surveillance and developing guidelines, we also publish. So here are just 2 publications that have come out from CETNET as related to hepatitis C. There have been a number for other conditions, including COVID, but most recently there's been 2. So time of positive hepatitis C test virus results during the first year and 1 year, during pregnancy and the year before pregnancy. And then the other is birth outcomes among people with hepatitis C in pregnancy. And so these can be found on the CETNET website. And the CETNET website is listed at the bottom of the slide. And I just wanted to thank whoever created the CETNET site, as this presentation was heavily appended from them. And so with that, I'm going to turn it over to our first presenter, April, from the Arizona Department of Health.
Okay, there we go. Thank you so much, Fahad, for sharing our slides. I wanted to do an overview of the perinatal hepatitis C program. I'm also joined by Arlis Jenkins as well. And this is for the state of Arizona. I do want to say up front that we are a newer CETNET site. So we started submitting officially last year. So this is definitely like our experiences of getting the program started, learning about medical record requests, abstractions, all that fun stuff. So next slide. So we are from the Arizona Department of Health Services, or ADHS. We are committed to the health and wellness of all Arizonans. We're looking at doing up-to-date information and resources to keep Arizonans safe and healthy. And then our mission is to promote, protect, and improve the health and wellness of individuals and communities in Arizona. So I thought it was important to start with our agency. Next slide. So our hepatitis C team, we currently have 7 pictured members in the picture to the left. And then one not pictured is Lisa Najarian, who is our perinatal intern. But we have Dr. Fahad Akram, who's our senior epi, Priscilla Hernandez is our data entry specialist, Vera Bolby is our HCV communicable disease investigator, and Arlis is our fearless leader, our epi program manager. And then Dr. Whitney Mabara, I'm so sorry, I'm having like issues speaking today, is our CST epi fellow. I'm our perinatal epi, April, and Saul is our patient navigator. Next slide. So I thought it was important to start off with what the numbers look like in Arizona as a whole before we talk more about the perinatal program. So in 2022, we received an estimated 8,800 reports of hepatitis C. And in 2021, we received 11,600 reports, which is a 24% decrease between those 2 years. CDC has also seen a significant slight decrease between 2021 and 2022. But it's too soon to say if that's a true trend. When we calculate rates for Hep C reports per 100,000 persons, there are a couple takeaways. Rural areas in Arizona have a higher rate than urban areas, such as in Mojave County, which has 230.62 Hep C reports per 100,000 persons. The highest volume for Hep C reports is still found in Maricopa County at 58,556 reports, or it accounts for 57.8% of the reports received for the state overall, which tracks with other records we've received where it's like 50% that Maricopa represents Hep C reports. But I will turn it to the next slide and turn it over to Arlis to learn more about our implementation goals with CETNET.
All right. Thank you so much, April, for detailing what our team looks like now and what we understand today about the burden of Hep C in Arizona. But we're going to go back in time to when we first were introduced to the SetNet program, which was in 2021, and things looked quite a bit different back then. So at that time, when we first had sort of initial conversations, the team consisted of myself, and we had one CDC public health associate, which is an amazing program. We strongly encourage you all to use it if you aren't. And then we were in the process of hiring our first epidemiologist. So we were not conducting hepatitis C case investigations at this time, and we hadn't really started thinking about perinatal hepatitis C at all. So this really led us to establish two large goals, sort of right out the gate. The first was to really understand what a perinatal Hep C program could look like, even beyond SetNet, thinking through what we would like to see and understanding what our capacity would be. And then the second one is always crucial, which is data. So we knew we needed to develop a hepatitis C person-based registry. And this was something that was already in the works, but we kind of saw would be extremely helpful for the SetNet program as well. You can go to the next slide. All right, so we have a timeline on the right to kind of detail what this looked like. So as mentioned, it really started with some initial conversations. Our STI team was already part of SetNet, looking at congenital syphilis, and they approached us to free up room in their budget to add perinatal hepatitis C. So we knew this was an amazing opportunity. We wanted to take advantage, but thought there would be a lot of need to learn quickly. And similar to many on this call, we were deployed to COVID. So, every other week we were doing COVID and then we were doing Hep C. And we were working on a lot of data improvements as well that I'll talk about on the next slide. So a lot of momentum picked up when my co-presenter, April, joined the team in April of 2022. So she took an interest in perinatal and became the perinatal Hep C epidemiologist. We also hired one other epidemiologist at that time, Fahad Akram, who's also on this call. So that really allowed for the time and dedication needed to focus in on learning the SetNet program, going through all the amazing resources the CDC team provides, and thinking through critically, how we can implement this. Another crucial part was receiving TA from NASTAD. So we reached out to HepTAC Center and were immediately put in touch with a lot of other jurisdictions where we got great insight onto what this could look like, whether we chose to work retrospectively or progressively, and some were sampling and some weren't. We've listed some of the states on the left-hand side, although I think the list is longer in that sometimes we receive TA for outbreak or case classification, and thankfully we were able to talk about perinatal kind of across the board with other jurisdictions. So really appreciate all of that support. That combined with some of the internal meetings we had, which was around summer of 2022, really helped bring things together. And another key piece of this that April helped with was staying organized. So we did a lot more strict agendas. We asked some of the same questions to different groups to really get a sense of the variation. And we had a running Q&A list with our SetNet project officer. So there was a lot of conversation, discussion, and thinking through and finding out new pieces of information. In October of 2022, we were able to hire two DIS, disease intervention specialists. And at this point, we had started general case investigations just a few months prior. So they helped us build and expand upon that. And then we were able to layer on the perinatal hepatitis C investigation as well. So that involved a lot of medical records requests and medical record abstractions. But having the team to support that was absolutely crucial. And that led to our first initial test submission, as April mentioned, just about a year ago. We were able to successfully complete that. Next slide. Okay, so during that same time frame, a lot of the focus was on that second goal as well, which is improving our data management. And we were looking to develop a registry. So within Arizona, we have a homegrown infectious disease database called MedSys. Even back when I started in 2019, that was the goal, getting the Hep C data out of an Excel database and into MedSys. So in order to accomplish this, we had very regular meetings with the MedSys team, the electronic laboratory report team as well. And we were able to start having electronic lab reports go into MedSys in 2022. And then we worked on doing a large upload of almost 100,000 rows of data going back from January 2014 to what was then present day, October of 2022, to place that in the system. And then we spent months deduplicating, and thankfully MedSys had some automation there for a certain threshold, 98% or greater, but we also did manual merging, a lot of data cleaning to catch up on that. But it was great to begin utilizing some of the advantages of MedSys. In order to get ready for perinatal and for SetNet, we had some additional work. So we developed a maternal infant DSO, which is a disease-specific observation, and that's what we call our case report form. So that took some time, kind of just understanding the SetNet variables and interpreting that in a way that made sense for the database. And then we also leveraged what we call the prenatal management table from the hepatitis B team to link the birthing parent and the infant together so that we can recognize that linkage when we look at data on the back end, and it helps with our programming as well. The last piece for MedSys was to create some custom data extracts, and we just wrapped that up a couple weeks ago. So we're very thankful to now have the custom extracts we need to submit quarterly to CDC. And this past submission was the first time that we were able to submit data that was housed in MedSys for the quarterly report. So we are very thrilled with the progress there. Another key part, though, of putting this all together was cross-matching. And back in 2021, we had not yet cross-matched any data. Thankfully, we had a HRSA-SPINS grant at the same time where we received some TA from Yale University. And through that partnership, we were introduced to Match Pro, which is what we use to conduct our linkages or our cross-matching. And we were able to match our hepatitis C electronic laboratory reports to the birth records. And we'll go through that in a little bit more detail on the next slide. All right, so looking at this cross-match in particular, we had our hepatitis C data going back to January 2014, about 73,000 reports. And the birth records, we narrowed in on January 2018 through December 2020, deciding to work retrospectively to allow for the 2-year, and we later changed it to 3-year follow-up period to follow infants. So by selecting this, we were hoping to ask for records one time for a broad enough timeline to get all the details that CDC is looking for the SetNet program. Our cross-match really looked at first name, middle name, last name, date of birth, but we later went in and did some partial matching and some extra checking on that as well. And that resulted in just over 1,300 birthing parent infant pairs. So that really speaks to exposure in the state of Arizona and kind of the larger scope of what this issue looks like. You can go to the next slide. All right, because SetNet has specific eligibility criteria, as mentioned earlier. So that was our next step, which was to apply what's listed there. So only pregnant persons, RNA positive during pregnancy or 1 year prior. So we excluded everybody else. And that left us with 292 birthing parent infant pairs that we are actively requesting medical records for, following up on, conducting abstractions. We break it down into about 40 per quarter. And everybody on our team knows how to abstract, although the bulk of it does go to our DIS team, who are amazing and dedicated at getting that done every quarter. Next slide. Okay, want to detail some of the specific demographics. So out of the 292 birth events, or infants rather, you can see that a lot of them are heavily concentrated in Maricopa County, where that dark orange color is, and that's where the city of Phoenix is, closely followed by Pima County, where Tucson is located. And we do have some scattered throughout in some rural areas, although we had to suppress some, really just showing kind of the scope of where these individuals are residing. When we look at the birthing parents, because some of them the children are twins or triplets, we had 279 birthing parents. Race ethnicity showed that 79% are white, non-Hispanic, and the average age at time of delivery is 30 years. And then lastly, at the bottom, want to showcase sort of what that looks like from 2018 through 2020. We do see the majority of the birthing parents, infant pairs in 2018, followed by 2020. But somewhat consistent across the board. And we are still very much learning from this cohort and collecting data to better understand what's going on. So we look forward to having more information to share in the future, but I'll hand it to April to share a little bit more about some of our initial findings.
Okay, yes, and we do have more information. I'm happy to share from, we submitted an abstract to City Match, so there's other data that we've compiled, but I know if the time limit for today, I did want to focus on the testing appropriateness for the infant. So I wanted to start off by saying out of our initial match with the birthing parent to the ELR reports or electronic laboratory reports, we did that cross match, but we also did a second one to account for infants that their mother or their birthing parent might not have been captured with an RNA test. Maybe they had testing prior, but that captured in total 37 infants when we did the birth records for 2018 to 2020 to the electronic laboratory reports. We extended out the time frame to account for the infant being tested at 2 years of age or 3 years of age for 2018. Let me see, I think it was 2018 to 2022 is the testing data that we did. And this is our second lineage. And in between those two, so the 37 overall, 10 of them overlapped with the ones from the linkage with the birthing parent to the ELR reports. So there were 27 infants that were found in this linkage that were not found in the first with just birthing parent to ELR. Okay, so a majority of infants, 37 out of the 319 of our total cohort, didn't have evidence of Hep C testing from that linkage of ELR to birth records. And that is a very low number out of 300. For this graph that you see here, we were using older testing recommendations because I know just last year they had the new ones come out. So there was a time frame of 18 to 36 months of age for the antibody test and 2 to 36 months of age for RNA tests for infants. And I can put that in the chat after I present this slide. So for this time frame, we do want to refine this graph in the future to show more of like when it's outside of the time frame to like more clearly show if it's before or after. But appropriate testing fell within these timelines. So 18 to 36 months of age for antibody test and 2 to 36 months of age for RNA testing. So anything outside of that time frame we found as inappropriate testing. I know there's the new recommendation for Hep C testing for all perinatally exposed infants at ages 2 to 6 months with a nucleic acid test for detection of Hep C ribonucleic acid or RNA, and then referral to a healthcare provider with expertise in hepatitis C management. But since this is a retrospective cohort, I looked at those older timeframes, and with those findings, there were 9 appropriate tests for antibodies and then 8 for RNA that fell in those timeframes. 28 of the antibodies fell in inappropriate timeframes and 6 of that for RNA as well. So 76% of infants tested for antibodies and 43% of infants tested for RNA were tested at inappropriate times. And I do want to specify this is for 37, so it's a small number. And then 37 had an antibody test and 14 had an RNA test. Let's see. Yeah, that was the big takeaway from this slide. And then next slide. There were some challenges we encountered with participating in the SETNET program. The first was figuring out who the provider was. So with birth records, you get the hospital information for who to reach out to for delivery records for mom and baby, but that doesn't necessarily give you a pediatric record until you receive the delivery record. So we utilized our ADHS STI team, and they use the Arizona State Immunization Information System, or ASIS, to identify that information. So that was a great help to find pediatricians. And then later, when our team got access to health information exchange, that also helped with pediatricians. Maybe the infant just got immunized with one provider, but that wasn't their regular provider. So health information exchange really helped to find those gaps in the data as well. Another challenge was creating protocols to match our electronic laboratory reports, ELR, to birth records, and also to syphilis SETNET data. So we did do cross-match with our sister program at the STI team. So we hadn't done this before. It was great to have the HRSA SPINS SOP protocol to develop the matching process with internally, but also with the ELR and birth records. Also building processes for requesting records and performing abstractions. Abstractions were it was a learning process to find out the best way to do that. We went through different iterations. I will say we first learned with Adobe Acrobat to save it as a Word document so you could search for keywords. But we now use Scan and OCR, and I have to say thank you to Vera and Saul for helping to make this process a lot better, because saving it as a Word document was not fun. And it took a while to save, but through trial and error, we found the best way to search for keywords around different medical conditions and milestones for baby and mom. Also building in blocks of time to dedicate to abstraction, not having and having patience when reading through the record, because some of them are hundreds of pages long. Medical record requests, we request the record 3 times from a provider. And like I said, we use Health Information Exchange, HIE, and ACES, our immunization database, to try to find those providers. Also, we've called facilities to confirm fax number, because there is one hospital system that it changed, I think, like 7 or 8 times. And I could tell when it didn't go through that wasn't the right fax number. Also being clear in requests for what you're asking for, such as medical records and labs, because sometimes they just send the medical records. There's no labs in there. So I have to say thank you to Vera for that, and updating our request letter that we send to the providers and to the pediatricians. So that adding that lab language increased the number of lab reports we received. Also, medical records come from a lot of different sources, faxes, mail, and also electronically. We've even got a CD-ROM in the year of our Lord 2024. And Arlis had a computer on site that had a CD-ROM. My laptop does not, so that was really helpful. Also addressing when you receive an infant record under their first and last name for the mom, because sometimes they don't have that full name of the baby that you see in the vital records. So maybe calling them baby boy Smith, baby girl Smith, or whatever the last name is for mom. That has been helpful in some cases where it was difficult to find the infant otherwise. Next slide. So looking ahead, we have some fun stuff coming up. We had our abstract for an oral presentation was accepted for City Match conference in September, and we're looking to have Dr. Whitney present, and we're still waiting to hear for travel approvals for that, but that should be really exciting. We have a KAP survey, which is a knowledge, attitudes, practices survey that's been finalized, and we're looking to disseminate it with Arizona providers to get an updated understanding of their knowledge, attitudes, practices around perinatal Hep C. This was done previously about 5 years ago, but a lot of things have changed in the perinatal Hep C landscape. That would be great to find out what they think of all the changes, or even if they're aware as well. We also have every 2 months an all-member meeting with Hep-Free-AZ to work towards a Hepatitis C-free Arizona with presentations by community organizations and outreach events. We have administrative code changes where we're looking to have pregnancy status reported, and hopefully that will go through, and that would make that part of the process more smoother. Process improvements, we are looking at requesting electronic health records instead of requesting records from all the facilities. That would help improve our reach and cut down on all the time that we put to a medical record request for the team. And then also expanding health information exchange access for the entire team. We got another member of our team to have it, so I'd say like about 50% have it now. Education material development and dissemination. We developed a materials with Arizona American Academy of Pediatrics, AAP, and our ADHS STI team for providers, OBGYNs and pediatricians. We want to disseminate these materials to providers in the future, and I can link those once I've finished speaking. So hold on just a moment. But SetNet has provided a great foundation for understanding the scope of the problem and specifying details. We are now well positioned to respond to the needs of our community. Some ideas we're looking into expanding is our patient navigation program to better focus on parents and infants in real time rather than abstractions. And next slide. We have 2 different email boxes. We have our hepc@azdhs.gov, which is like our internal team, but HepFreeAZ is our coalition group as well. And their email is hepfreeaz@azdhs.gov. And shout out, they have a meeting coming up in July, I believe July 29th at 12:15 Mountain Standard Time. So yeah, and I think that is our last slide, or yeah.
Well, thank you, April and Arlis, for such a great presentation. I would say that unfortunately Rachel is unable to present today. So now we have 26 whole minutes for questions. So feel free to raise your hand or drop it in the chat. I'll start with the questions in the chat, and then we also have some ones to get the discussion going. And since the other jurisdiction is unable to present, I will chime in for some Tennessee stuff so that Arizona is not put on the spot. But anyone in Tennessee on the call, either a present member or previous member, also feel free to jump in as well. Okay. So the first one has already been answered, but honestly, I'm going to look this up as well because I've never heard of it. Was what's the name of the software you use for medical record abstraction? And so it's Adobe Scan OCR, which is really cool. So we will look at that as well. The next question was from Deborah asking, what benefits did you see with cross-matching perinatal HCV cases with congenital syphilis cases?
Such a good question. And, you know, I don't think we uncovered a lot of matches. April, you might have more insight on the actual numbers, so which is good, right? We don't want to see high numbers there. But it was really helpful in just solidifying sort of our relationship with the sister program and getting that proof of concept, the fact that we can cross match. I think it opens up things in the future for more collaboration and already the idea to cross match a little bit more broadly. But yeah, I wouldn't say that it's led to a ton of changes in terms of our follow-up necessarily due to the low volume. And this was mainly sort of started by CDC. So because we're sending data from the same site, it's important to them that we cross-match so that we can use some of the same identifiers. But I do think it'll have a lot of long-term positive impact as well, just in that we're talking and working together a little bit more. I'm not sure, April, if you have anything you'd like to add.
Yeah, in that process, we found so far 5 mother-infant pairs that matched the SETNet criteria for congenital syphilis and Hep C together, and we would redo that match every quarter just to verify. I think we do want to continue matching with them in the future as well, just to keep expanding that, because we're looking to do birth defects and I think the neonatal abstinence syndrome as well. But they also pull their data out of a different database, PRISM. They are not in our state database. So it was a lot of coordination working with their team and having a SOP and protocol to make it easy on them. And then our team would perform the match to take that burden off of their team.
Interesting. Yeah, I would say from a Tennessee perspective, so we were not a syphilis funded jurisdiction. We actually just applied in the new NOFO. And so we have already been meeting with our STI team to really figure out like how this is going to work, because I think we envision, so we use REDCap to store our SETNet data. And with COVID and HCV, we just kept them separate. Like they were too different with the way we identified them. And there were so many different variables and different people working on it. But with syphilis, because we're both housed in the same section, because we're HIV, STI, viral hepatitis, that we're like, we want them to be together. We want them to be within one record for follow-up. But we're dealing with a situation where they were in prison, but they're slowly migrating over into our disease database. We use the NEDSpace system. So that's been tricky because we're like, how do we develop it now? Because some of the stuff is still in prison and hasn't made the move. And so we might have to adapt, but that's really cool that you cross-match. Do you have a lot of overlap? I sorry if I missed this. Do you have a lot of overlap in syphilis and HCV cases?
With
So
the
this was our, oh, sorry, I was going to say it was our first match, April, and I think you shared 5. So I think we have yet to really look into that and see what it looks like in general. Were you going to add anything, April?
Oh no, that was perfect.
Yeah, I would say like when we link with our neonatal abstinence syndrome. We've done that outside of SETNET, but we also do it within SETNET. But we find that close to like 40% of our cases have an NAS diagnosis. So 40% of our perinatal exposures. And so we've been kind of discussing with Family Health and Wellness on like, how can we, do this together? Why are you contacting them about NAS and then we're contacting them about hepatitis C? And so we're like, let's save money and time by working as one. Okay, so let's see. From Leilani, for the order of linkage operations, do you link HPV data to syphilis and then to birth records? Oh, I saw that you answered this. If you want to just
to say it out loud, we have not. Yeah, we did the cross match with birth records first and then matched. But I'm thinking this is something that is very doable and something we'd be interested in next. I know Arizona is with congenital syphilis, the numbers are quite high. So very inspirational question.
anything to add, April?
No.
I'm trying to keep up with what's the difference between the questions and then the comments. Oh, so you discussed on appropriateness of infant timing. So it's 18 to 36 months for an antibody test and 2 to 36 months for an RNA test. And I will also say in Tennessee, we have a hard time because some of our providers are just like, nope, we do antibody and reflex to RNA. And so they're testing between the 2 and 36 months, but they're starting with the antibody. And if positive, they're going to reflex the RNA, which is frustrating for us because it doesn't count because they just come in as an inappropriate antibody. And then also some of our providers are like, until we can treat them, we don't want to test them. And so then they're waiting until they're at 3 years or right over. And so they're not considered a perinatal case. Do you guys experience that? And then what's sort of your methods for outreach and education?
I think we're still rather early on. Now that we've hit sort of a year of data, we're really looking back and analyzing and trying to understand. But as April mentioned, a lot of the infants, we do not have documentation of testing at all. So I think what's next for us is really looking into that more and trying to better understand that. I'm curious to the thing you said last about providers maybe waiting, that'll be interesting to kind of learn more about as well. But we are also working with AAP and really just kind of trying to get in contact with this network and establish, who's who, kind of similar to what we did for general Hep C as we worked on our elimination plan. Really just having those conversations and kind of making it known, who we are and what we're doing and the fact that we'd love to work with providers on this issue.
And I do want to add for Hep C, we get the negative, or we don't get negative reporting unless it's part of a panel. So I think it would be interesting to go back through the cohort and see if we could get like their negative reports, maybe through HIE as like a quick look, but that's also another disadvantage as well.
Yeah, I would say in Tennessee, we experienced the same issues. We actually had a few years ago, we called it our Under 3 project. And so we went through all of our perinatal exposure starting in 2018 to the start of SETNET. And we requested the records because we were like, none of these infants are getting tested. But then when we started requesting, we're like, oh no, they're antibody negative. And so we discovered that they're just not being tested appropriately. I would still say that we do have like discordance in testing rates depending on like where you live in the state. Like typically in our more Appalachian region, they are better at testing. I like to say that that's because where our SETNET is based, but I think I'm biased. They also do have like a heavy burden of hepatitis C. And I would say for our SETNET cohort, as well as our established perinatal statewide program, we now request labs as soon as the infant turns 18 months. And we just follow them until they're 3 years of age by contacting the birth parent or the current guardian or even child services to really educate them on getting their infant tested and the importance. And we will do it until they turn 3, which is not nagging. I think it's really great because sometimes it takes many attempts, but then the infant gets tested, and we really just don't want to miss any positives since treatment starts as early as 3 now. Okay, so from Jenny, 3 Any tips for babies who enter fostering or adoption situations? So thinking both about identifying those cases and following up.
We have encountered some infants and children that they were entered into the foster system and then their name changed from what was on vital records. I think what helped us identify those was when we received the delivery records, it would list baby is now, insert new name here. And then we would search our immunization database to see if we could find the pediatric provider for that infant or child. I think I've heard from our surveillance team for other infants that we've encountered where we couldn't find the pediatric records and they might have been in the fostering system is they were mentioning a strategy to look at like the date and the time that they were born at the specific hospital to see if they could be narrowed down in vital records if they're under a different name. That's one strategy I heard from them. That was another approach we were going to look at with our data for going back and trying to complete data collection for some of the infants that we reached out, but they're like, we didn't have an infant by this name here. So that's some of the approaches I've heard of from that we wanted to try going forward too.
Yeah, and I would just add, reaching out to the maternal child health team has been super helpful. They're in a separate division, and we just didn't talk previously. So getting to know some of the folks there have given us a lot of good insight, and they've opened the door as well. I think if we have a really challenging situation, they're like, "We love challenge," so they're very open to supporting. So that's been huge as well.
Yeah, I would say in Tennessee, our family health and wellness program, we went from, kind of having conversations with them every once in a while to really having this incredibly like strong relationship. Sometimes it almost feels like you're even one team when you're working on SetNet, especially during times of COVID, because like you never stopped talking to each other. And so that has been it's been incredibly helpful to be able to identify and reach out to OBs and pediatricians. And so, they have the list or they have the connections. And so that's been really great. I would also say in the state of Tennessee, we have a Project Echo at the state level, which has a special focus on pediatrics. And so we have a subject matter expert based in Northeast that's a specialist in treating children with hepatitis C. And so she's really been like a strong advocate for infant testing and treatment. And she's kind of been like our champion in helping us develop materials. And so it's kind of nice that you can just kind of identify these people that are just as passionate as you and kind of bring them in to help kind of overcome this disease burden. Okay, so next we have Dr. Douglas Thorpe. I don't know what these acronyms stand for, so apologies. Are you able to obtain data directly from AHCCCS apart from the HIE?
Yes, yeah. So our state Medicaid is called Access, Arizona Health Cost Containment Care System. At this time, unfortunately, we are not able to leverage their data. We are sister agencies, but separated just enough to make that a little difficult. Although I think we would love to partner with them, especially on perinatal hepatitis C. So we welcome that in the future. But in the meantime, HIE has been our health information exchange has been one of our main sources.
Can you what is your health information exchange? Does that like your access to your hospitals in your state?
Yeah, so it's actually managed by a third party org named Contexture, and they manage for the whole state of Arizona. I think a couple other states as well, where hospital systems or clinics can choose to share their data within this exchange, and then at the patient level, they can opt in or out of sharing their personal information. And the health department is able to have a login where we can look up patients. Unfortunately, we're not able to access extracts at this time, so it is individual lookup, but it's been very useful, especially more so in present years or more recent years. As we were looking back to 2018, it's not as useful, but it's been something that we're happy to have access to. Absolutely.
Interesting. I would say in Tennessee, we're working on it. We don't have one. I'm very jealous that you have one. I think right now we are working on getting access to it's like 17 different EHRs or whatnot.
Wow.
And it's just
Okay.
very overwhelming. I've heard it takes a day just to apply, and no one has been granted access yet. So we're still kind of in the trial periods. But right now we have access to two. So we have access to Vanderbilt, which is a huge birthing hospital in Central Tennessee. And then we have access to Ethan, which is our East Tennessee Health Information Network. And so that definitely helps, especially even if you have to request more records, but it helps you be able to like follow where people are and kind of know who to reach out to. So that has been exciting, but oh my gosh, I'm so jealous. Okay. I always get jealous of other states when they present on their access to things. And then in Tennessee, right now, we don't have access to Medicaid data, but that is something that we're actively trying to get a data use agreement. And I think that's kind of division wide. There's some interest. And so hopefully more to come, because that CSC a few weeks ago, I really enjoyed how they were utilizing it to like look up hepatitis C treatment info, because that's something we don't have access to. And I was like, I need this data, because it was so interesting to really help with their care cascade to identify those who actually were treated. Okay, lots of questions, so I'm going to keep moving on. So from Nicole, do you have access to medical records where the pregnant parent is incarcerated?
That's a good question. I think the HIV DIS team, April, if you would agree, just secured access to our state prisons EHR. But we have to kind of collaborate and work with them. They limited the number of users, which was our barrier there. But I think that seems to be our best way of getting more information about somebody within corrections, whether they're pregnant or otherwise. But yeah, definitely a challenge and something we're hoping to better understand in time.
I would say for Tennessee, again, we don't have access, so I'm just gonna be sad. But we do have a great epidemiologist who works for the Department of Corrections. But what's nice is at least they have like an online portal. I mean, it's incredibly rare. I mean, it happens that our pregnant people are incarcerated, but we do have kind of a portal where we can go ahead and request the record. And we do have an epidemiologist who we could reach out to if we're not able to contact them. The only issue is like what data they will provide. They're very hesitant to do any sort of risk factor data. And so that's been something not just for SetNet, but that's been especially difficult, like kind of looking at our care cascade and looking at infection in prisons as well as reinfection. And like without the risk factor data, we're like, okay, they came in here and they were negative and now they're positive. Like something had to have happened, but they're like nothing, because they won't share that, which I guess liability. Okay, Amelia says she's struggling with kids that are tested between 3 and 5 years of age, especially for case classification. I can speak to Tennessee and then turn it over to you guys. Same, it's so frustrating because these cases are perinatal suspect cases in our database, because we track all the exposures, and then they get tested at like 3 years and a month or whatever. And so then we have to leave them as suspect. And then we have to create a confirmed chronic if they're positive, or we can't rule them out. So that's our approach that we've taken, because we've really stuck to that 0 to 36 months. But it's frustrating, because yes, they could have acquired the infection some other way, but like in all likelihood, they probably did it perinatally. How do you guys approach those situations?
Yeah, we just started classifying for the first time, maybe 2 months ago. So we're in a pilot project phase. It's based solely on electronic lab reports. So we're batch classifying, since we don't have time to individually look at these things, as I'm sure many others can relate to. So the protocol, it would look at age and test result. And we can look at jaundice if we have evidence, or elevated liver labs if it's there. So yeah, I think it'd be similar to what you're describing, Heather. I think 3 months and 1 day would not be classified as perinatal based on our current protocol. And we have a lot of other challenges too, as well, that I think we'll get to look at in the next coming months.
Anything to add, April?
Yeah, I think like when we put the data into our state database because I know like 2018 to 2022, Arlis, I believe they're classified as perinatal when we put them into our state database, just so that the case report form would show as
Yes.
okay. because I know, I know they're older, but we needed the case report form to show for that retrospective cohort. But I think with our batch case classification, if they're older than 3 with this, with the way we're doing it, they're classified as chronic, I believe. Does that sound right, Arlis?
I believe so. Yeah, for us, they're 2 separate variables. So for perinatal, that would open up our case report form and allow for that entry. And then we have a separate one where it's acute or chronic, confirmed or probable, rather. So yeah, we're kind of looking at both of those and kind of figuring out, how best to use them. I think also, though, the fact that we're able to link the birthing parent and the infant could be also an interesting data point in that maybe they're not a perinatal case, but we can still see that, they had exposure possibly from that birthing parent. So definitely something we're going to have to put our heads into and think on a little more.
Yeah, and I will say for Tennessee, we don't have this batch processing. So a wonderful member of our SEDNet team or one of our data entry people, we actually enter the mom's pregnancy investigation and then link them to the infant. And what's nice is we have a person-based system, so it allows us to track multiple exposures. So if there were twins or if there's multiple pregnancies across the years, but it is fairly labor intensive. Luckily, we do have a lot of code to kind of quickly pull through people we need to focus on, like if there's a positive. And so we're not manually reviewing every single linkage, but it's still, I would say Tennessee it's been decreasing, but we still have an average of about 1,000 perinatal exposures a year throughout our state. And so it's just fun because we're also following them for up to 3 years. And so every week we just add more and more, but luckily we're seeing that decrease. Okay, so I know we only have a few minutes left, so I think we have just 2 comments. From Emily, for providers that want to wait till they're close to the age of treatment, I've used the argument that it's important for the family to know the infant's status for being mindful of household exposures and having infants' overall health monitored, since there's risk for cognitive, not congenitive, I was making my own word, cognitive delays. Yeah, that's a really, really good point. I know our nurse navigators really try to educate them on that as well, because it's a bloodborne pathogen, and so sharing even like toothbrushes could potentially lead to exposures. And then from Michael, in speaking with some investigators at the local level in California, I've heard a challenge is providers wanting to wait on testing until they're able to treat. But I think loss to follow-up then becomes an issue. So Michael, like another great point, and I think that's why they really push for RNA testing at 2 months, is because these infants at a higher proportion fall out of care compared to our more general population. That's at least what we see in Tennessee. I don't know, Arlis or April, if you see similar things.
That is a good question when I was typing. And if you don't mind repeating that just a little bit, and I apologize.
Yeah. So yes, we have some materials in our, yes, Arlis.
Oh yeah, that was me typing, and
there's multiple comments. So we have some materials and are happy to share. We can share them with NASDAD, but can also be reached at the email if there's any follow-up questions. So yes, that's a great point. I know we only have a few minutes left. Sakia, should I end there for wrap up?
Yeah, I think we can do a last call for questions. I see one for Rachel.
Okay, probably not enough time to get an answer here. We will answer it. But I'd love to hear about your experience using nurse navigators rather than health educator navigators.
yeah, in Arizona, we haven't used nurse navigators, but I will say that our intern, Lisa Najarian, is in medical school, and that has been amazing. She really didn't need much training. She took to it really quickly, pulling those abstractions. Her medical school is affiliated with the largest healthcare system as well, so there's a chance that she can access their electronic portal in the future. So I definitely interns, I think we've heard other states say that too, can be a great resource. Not sure, Heather, if you've had experience with nurse navigators.
So yeah, so we only utilize nurse navigators for our perinatal program. And so for SETNet, we have one, Laura Price, and then we also have a statewide perinatal program. And so we have a bunch of nurse navigators that work on other things, not just perinatal, but we have found that to be really successful because typically they have a lot of patient care experience, but they also have like that clinical perspective. So I really enjoy working with nurses, especially as like an epi. I'm so like data focused and I see the world in black and white like many data analytics people. And so I really, really like the nursing perspective because it's much more clinical and it's much more gray, I have learned. So I've learned to like come and meet in the middle. But I have heard really, really great things about them. And they also, tend to develop really nice relationships. And I think they're able to navigate as many people to care because when they call, they care about the patient and they stay with them until they can get them linked to not just treatment, not just infant testing, but really link them to every single service they need. I know Laura has mentioned a lot of mothers needing dental services, and that's something we didn't even think about. And like just listening to them and hearing their needs has enabled us to kind of expand the services we're able to link them towards. All right, Sakia, I'll leave it at that because I know we only have a minute. You guys are very good with time in meetings. I run over every meeting.
Oh, yeah, thank you. And I see, April, you responded to Michael's comment as well. So I guess folks can take a look at that. But I wanted to say thank you so much for our panelists and our moderator today. It was an amazing session. I know a lot of folks have been wanting to learn a little bit more about SetNet and see how they can use some of the processes y'all using for that program just for larger perinatal hepatitis surveillance. So yeah, we appreciate this great conversation and you all did amazing. So thank you all so much. Thank you all, everyone, for your questions and your comments and your support in the chat. And I guess we can end there. So thank you all so much. And we will see you all again on July 10th for our next VLC session. So thank you all. Have a good afternoon. And please don't melt. I know it's very hot.